and welcome to the next episode of TILLY, the interactive lupus link for you. TILLY is a weekly episodic series brought to you by the Lupus Foundation of New England. I'm your host, Marissa Zeppieri. Some of you may already know me as Lupus Chick. And tonight we have a great episode with a friend of mine. He is also a rheumatologist. He's based in Monterrey, Mexico. And we are going to talk about the ever popular question of people that have symptoms and are not feeling well. Do I have lupus? So we're going to look at common symptoms and what the process is to actually getting a diagnosis. So Dr. Kiber Gonzalez is here with us. I want to thank you so much for being here with us. And I would love it if you could just give our viewers a quick overview about your experience as a rheumatologist.
Well, I've been a rheumatologist now for, I think, 6 years ago, since 6 years ago. I'm currently in Monterrey, Mexico, and well, lupus is the always question of any patient who presents with arthralgia or fever, and it's our job to say it's not lupus or it is lupus. So I think this is a nice episode because we're gonna approach this topic that I think it's always in our heads. So I think it's gonna be nice.
Great. Well, thank you for being here with us. So I wanted
Thank you for having me.
Oh, absolutely. I wanted to ask you, what are, for people that are maybe going through a diagnosis right now or curious, is this really what I have? Is this why I'm feeling sick? What are the most common symptoms of lupus? And what do you feel when patients come to you? What are the most common symptoms that they're presenting with?
Okay, the most common complaint is because some other doctor made the anti-nuclear antibodies in this patient just because this test became in a panel of other tests, and maybe they went positive, the result positive, the anti-nuclear antibodies, and maybe the patient doesn't have any symptoms at all. And well, it's already known, and it's already overall everywhere that positive anti-nuclear antibodies is not the diagnosis of lupus. And the most common symptoms are arthralgia, which is pain in your joints, fever, maybe hair loss, and oral ulcers. These oral ulcers have the particularity that they doesn't produce pain, so the patient always feel it with the tip of their tongue, but they don't cause any pain. So this is like a key symptom. Ulcers that doesn't produce pain. Hair loss, as I already told you, maybe some type of rash or foamy urine, or I think also very common is the chest pain with the deep inspiration. Those are common symptoms of lupus.
Okay, so interesting. So I wanted to ask you, as far as the ANA, so we hear about the ANA test a lot. It's a very common test here in the United States. I'm assuming also in Mexico. And, people will ask me, well, I had a positive ANA, so that means I have lupus, right? And no, there's so many things that could possibly be a diagnosis with a positive ANA, correct?
Yeah, that's correct. We need to remember that almost any illness can produce positive ANA, okay? Almost any illness, but only 2 of them must have the positive anti-nuclear antibodies, which are lupus and systemic sclerosis. These 2 diseases must have the anti-nuclear antibodies positive. The other ones, it doesn't make the difference. Always, if we have, I don't know, typhoid fever, and we have nuclear antibodies that result positive. These nuclear antibodies are pretty common to be positive in infections and cancer. It always be a distraction, a confusing factor. So that's why we try not to ask them a lot. But now here in Mexico, the laboratories, I think that's a correct name, that make this test include the anti-nuclear antibodies within a panel with other other tests like rheumatoid factor, erythrocyte sedimentation rate, C-reactive protein. So they make this panel, and maybe most of these tests are not necessary, including the anti-nuclear antibodies. So we should remember that anti-nuclear antibodies, they are only telling us there is some autoimmunity in your body. It doesn't make the diagnosis of nothing. Even lupus, even systemic sclerosis, they don't make the diagnosis. They are part of the set of criteria that help to make the diagnosis. So making the relation, the straight relation between nuclear antibodies, positive nuclear antibodies, and lupus or systemic sclerosis is not a well thing to do.
Okay, so say we have someone who's not feeling well, maybe they're tired, they have the oral ulcers, things like that. Their primary doctor does a bunch of tests. One of them is in positive ANA. So now they get transferred or moved on to go see a specialist, which is you, the rheumatologist. So what is the next step when someone comes in? Are you looking at their symptoms, how they're feeling on a regular basis, and then you're doing more blood work? Like, talk someone through what the next steps are.
The next step will be a thorough interrogatory and searching for another type of symptoms. This could take about 40 to 1 hour, 40 minutes to 60 minutes. And then we must go to the physical examination, that this can reveal tons of information. And after that, we can now decide which symptoms, which results of the physical examination are relevant. And based on that, we can choose which blood work we're gonna make. Usually for the diagnosis of lupus, we should at least have some tests done, like anti-DNA, the anti-Smith antibody, the complement, C3 or C4 complement, the anticardiolipins, and the lupic anticoagulant, and the, I don't know how to say it in English, but I think it's beta-2 glycoprotein 1.
Okay.
These last three, the lupus anticoagulant and the anticardiolipins and the beta-2 glycoprotein 1 are also for the diagnosis of antiphospholipid syndrome. But in this case, we can use it also for the diagnosis of lupus. So, but if the physical examination and the interrogatory doesn't lead us to that place, it will be very risky to make this blood work, because in case the anti-nuclear antibodies are positive, in case of if the complement is low, which low complements mean it's positive, it's not always lupus. So we must have a convincing interrogatory, a convincing physical examination to make this blood work. So I think it's very important that the patient dictates us the path we're going, not the blood work, not the results of the blood work. So the patient is far way important than the results of the blood work.
Okay, so I think that's something that's really important to focus on here. Is I want people to understand that lupus isn't like this simple diagnosis. You don't take one blood test with just one thing that you're looking for, and it's positive or negative and you have an answer. So you're really looking for them to verbally tell you things that they've been experiencing, and then you're doing your physical examination, and then you're going to go further and look at a lot of different blood work to actually be able to make the designation of lupus, or maybe it's some other type of autoimmune disease, right?
Right, because as I told you, that the anti-nuclear antibodies may be positive in a lot of diseases, including rheumatoid arthritis, vasculitis, systemic sclerosis, dermatomyositis. I wouldn't end, even if I only take time to explain all the autoimmune causes of anti-nuclear antibodies. But now we have cancer, we have infections, we will never end. So
Right.
we have to take in the patient, the information of the patient, and then ask for the right blood work. Also, another blood work that is I forgot to say, we have the levels of the white blood cells, which are the leukocytes, are very important, and are also a criteria for the diagnosis of lupus. Also, fatigue is a criteria for lupus. In the new criteria, I think the new criteria are from the 2018, 2019, and are pretty simple to use. But it always depends on the patient, not the blood work. The blood work is, even if the blood work is positive and the patient doesn't have any symptoms, doesn't have any problems, the patient doesn't have lupus, even though the blood work is positive for lupus. It doesn't mean that we shouldn't keep an eye on it every 3 months or something like that. But it doesn't have the disease until something appears on the patient. So we're not trying to make any diagnosis just for making it. We're going to make it when it's time to make it, and it's time to make an intervention like treatment, right?
Right. So that was something else that I wanted to talk to you about. There's two things. First, there's different variations of lupus. We know there's systemic lupus, there's discoid lupus, but I really want to talk about severities. So like you said, it might actually show up in their blood work, but they have absolutely no symptoms, so they maybe don't need any treatment. And then you have people that are on the opposite side that have severe symptoms. Their blood work, is completely off, and they need very heavy duty treatments to prevent organ damage and organ failure and things like that. So would you say like that there's mild, moderate, and severe lupus, or how would you categorize that?
Well, discoid lupus is a far apart type of lupus. It's a manifestation, it's a disease per se, and it can be in the spectrum of manifestation of generalized or systemic lupus erythematosus. But discoid lupus is an entity apart of lupus that can be in the systemic lupus erythematosus. I don't know if I can made myself clear. It's an entity apart. It's not lupus. It's not systemic erythematosus. Erythematosus lupus is an entity apart. The lupus, the systemic one, can have discoid lupus. Okay, but discoid lupus is not systemic lupus. I think I made my point. And in the case of severity, there are no categories. There are no. This is chapter for mild lupus. This is chapter for moderate lupus, high lupus. We can make attack on the lupus based on the severity. We have some scales like SLEDAI. SLEDAI is a very common scale that we use in lupus that takes in account the patient of the symptoms of the patient, and the DNA and the anti-DNA antibody, and the levels of low complements and the levels of white blood cells. And based on these scales, we can tag the lupus as mild, moderate, or severe activity index, like I said, a severe activity index, because there's no separation in between this type of lupuses, if I may use the term, because there are no several types of lupus. There's only one There's only one systemic lupus erythematosus. There's no other one. That it has a lot of symptoms, and some symptoms can be present in one patient, and another patient have totally another set of symptoms. Doesn't make them different. They are the same disease, and they should be treated targeting the symptoms that the patient had. And so there are no so-called different types of lupus. Discoid lupus is another branch that mostly always the dermatologist is who treats the discal lupus, also which once or two visits to the rheumatologist a year for any, because only 5% of the patients that have discal lupus will progress to systemic lupus erythematosus. So it's very low percentage, and usually the dermatologist will take care of the patients.
Okay. So let me ask you, when someone comes in, you've done your initial exam with them and you've gone on to do more blood work. If you are diagnosing someone with lupus, how do you figure out your treatment at this point, and what does treatment look like?
Okay, there are some, like, I don't like to say it, but they are some like kitchen recipes. Like we need to start to use, if there's no contraindication, hydroxychloroquine. It's proof that the patient that with the diagnosis of lupus will have a better prognosis and the lifespan and the damage and the disability if they use hydroxychloroquine right away. Especially this hydroxychloroquine will protect the kidney, will protect the hair, will protect the skin, will protect the joints. So it has a lot of impact on the patient with lupus. Another part of the treatment, I will say that we use usually vitamin D or D vitamin because we in some studies made by the Dr. Michel Petrit, who's a lupologist, very famous in the United States, found that the levels of vitamin D on the blood, if they are low, there are more risk that have problems on the kidneys. So we need to always have the normal levels of vitamin D, and also the famous sun blocker, right? So these are the three things I think with all patients with a mild disease, like just arthritis, just oral ulcers, maybe some hair loss. I think these are at least these three ones, they must be on the patient. But we can use methotrexate to control the arthritis, to control the hair loss, even though paradoxically, I think I told it right. The methotrexate can cause some hair loss, and it depends on the manifestation of the lupus. So it's not the same for everyone.
That was great information. So I actually wanted to ask you, there are some other treatments besides hydroxychloroquine, and I don't even think we talked about steroids yet, but there's also some more like immunosuppressants or biologics. So tell us a little bit about those and when you would use that for a patient.
So we use a lot of mycophenolate. This drug is particularly useful in the patient with lupus nephritis. So this is very, very, very useful. There's another one that is called cyclophosphamide that is pretty awesome. It has a little bit more side effects, but it works pretty well. They will be used mostly in the problem of lupus nephritis. And there's another one that is called Hemiran or azatioprine. The azatioprine, we also use it in lupus nephritis, but as a maintenance program, not as a induction to the remission. We use it as a maintenance after, I don't know, 3 or 6 months of use of the mycophenolate, then we change to azatioprine. It could be one way, or we can only reduce the dose of the mycophenolate or the cyclophosphamide. That depends of the rheumatologist. We also use a lot of Benlysta, that is a biologic. The real name is belimumab, and it attacks the cells that produce the antibodies. So we should remember that in lupus, the antibodies, our own immune system produces antibodies that marks our organs as some foreign agent. So they suffer the attack of our immune system. So the Benlysta, the belimumab, and Mabtera or rituximab they both attack in different ways. These cells that are called lymphocyte B, they attack this type of cell that and make reduces the production of antibodies, so the immune system cannot mark our organs, and the attack will taper down. So these last two, I think they are pretty useful. I like a lot the rituximab because you can use it like one infusion at week 0 and one infusion at week 2, then every 6 months like that. The infusion, it will take some time, about 6 to 8 hours, because it must be a low rate of infusion, but it's quite effective, very effective. Mostly of the patients I can taper down and take out the steroids with the use of rituximab and belimumab, which is Benlysta. Not the same case with mycophenolate and cyclophosphamide or azathioprine, that I can also reach that point to taper down and get rid of the steroids, but it's not as frequent as with Benlysta and rituximab. These two have the caveat that are pretty expensive. So that's the problem with these last two, the rituximab and the belimumab, but they are quite effective.
Here in the United States too, I'm not sure obviously of the Mexican prices, but in the United States they are more expensive as well.
Yeah.
Well, this was all very helpful. I did want to ask you, we're friends on Instagram. That's how we met. You've been very helpful over the years. So if you can tell everyone, actually, there's two things I wanted to ask you. One, what advice or just encouraging words would you have for someone that is getting a lupus diagnosis? And also, if they wanted to follow you and learn more, how can they find you?
Okay. The first advice I will tell patients that have the recent diagnosis is get some help, not from the rheumatologist, but from someone who can help you to cope with this information. Some thanatologist or some friend, some meditation. This part of the medicine is, I think, that is not taking into account the frequency that we must take it in account. The patient must be coping very well with the symptoms, with the diagnosis, and if we don't attack this part of the patient, it probably make the patient to not take the pills, to not follow instructions. So we need this part of the mind to be as well as the immune system. So I think that's my first advice. My second advice will be follow the instruction of your rheumatologist. I know they will seem a little bit harsh, but follow the instructions. You must remember, if we see this cold, we see this problem cold as it is, we can, you must be, if I see you as a client and not a patient, you are my best recommendation card. So I will make anything on my power to make you get better. So if you see our relation not like patient, doctor-patient, if you see me like provider of service and a client, you must see that I want the best for you, because I want your recommendations. That's a way to think it. So you can, assimilate that we want the best for you. We don't want to give you steroids if you don't need them. We don't want to give you chemotherapy if you don't need them. But if you need them, we will prescribe it for you, to you. So follow the rheumatologist instructions. And if you want to find me on Instagram, Dr. like doctor, Kiber, Kiber, GZZ. C, right? Yeah, C, I think. Z.
I'm going to actually post it under you right now so that everybody can follow you.
I'm on YouTube like that, Dr. Kiber Gonzalez. I'm on Facebook like that, and everywhere. in Twitter, Dr. Kiber Gonzalez. I'm quite like that.
Perfect. Well, I'm really excited that you came on the show. Thank you very much. And
thank you for having me.
Absolutely. We're going to do one in Spanish next, I think. Well, you're an amazing doctor, so amazing rheumatologist. So thank you so much. You've been so helpful to me, and I appreciate you giving all this information. So I am going to post Dr. Gonzalez's information here, so you can follow him on Instagram, YouTube, Facebook. And I just want to thank you again, and I want to thank everyone for watching this episode of Tilly, and I hope that you'll come back next week and listen to our next episode. So have a wonderful night.